Welcome to the Motivational Midwife. My name's Lynn Jones, and today we're going to look at drug administration and the midwives exemption. So we're going to look at drug administration and midwives exemptions, a little bit of a whistle-stop tour over the sort of skeletal framework of it. I'm not going to go into great depths about actual administration of drugs. So firstly, look at what our NMC, our governing body, actually tells us about our role within this. And so the code states we should advise on, prescribe, supply, dispense or administer medicines within the limits of our training and competence, the law and our local trust policies as well. So within the limits of your training and competence means you can't actually prescribe medications unless you have done a recognised prescribers course and you're on the register as a nurse or midwife prescriber. And then our standards of proficiency actually state that we should be working in partnership with women to assess and provide the care and support across the whole of the continuum, making sure that we actually safely administer those medicines. So equally, that includes teaching them appropriately if they're going to be self-administering any medication. So, for example, things like Delta-Par and Clexane. And also that we demonstrate an ability to safely supply and administer medicines under the human medicines regulation. So that's our midwives exemptions. Now, the key thing to remember there is that we are supplying and administering medications. We are not prescribing them. And often people get confused around that, particularly when you're documenting it. So whatever your documenting regime is, usually there's a box on there for the person that's prescribing it to sign their name. So if we are administering under midwives exemptions, then what should go in that box is ME, or in full midwives exemptions, because we are not prescribing it, we are supplying and administering it under those midwives exemptions. And we need to check the risk regularly, because actually drugs come on and off it all the time. So what legal sort of legislation governs this? So the Medicines Act of 1968 defines our three legal classes of drugs. So that's our prescription only, our pharmacy and our general sales list medications. And then the Misuse of Drugs Act, which was set up to prevent the misuse of controlled drugs mainly, that further defines sort of class A, B and C drugs. So your class A are the most dangerous drugs. So that's things like cocaine, LSD, heroin, all of those. So our diamorphine, things like that would sit in those. And class B drugs are things like codeine, cannabis, all of those drugs. And then class C might surprise you that they all sit under there. So things like benzodiazepine, so that's your sort of minor tranquilizers, things like lorazepam, our nitrous oxide, so Entinox will sit under there, GHB, anabolic steroids, they all sit under those class C drugs. And then the Human Medicines Act covers all the other aspects about manufacturing, import, supplying, etc. And there's the Human Medicines Act is where our midwives exemptions sit. So looking at some common abbreviations that are often used, we've got prescription only, pharmacy medicines as a P, PGD, patient group directives, general sales list, and controlled drugs, CDs. So we'll just talk a little bit more about those. So prescription-only medicines, pharmacy medicines, P medicines, do not need a prescription. However, they are only sold by pharmacies by the pharmacists themselves or staff that are working under pharmacy supervision. So, for example, I suffer with migraines quite badly, and I vomit a lot. So I have a buccal medication, which is Stematol, an antiemetic, but it goes in your along your gum line and it dissolves. Now, historically, I used to have that on prescription, but that has now, some years ago, been moved to a pharmacy medicine. So I can buy it across the counter, but only from a pharmacist or staff working for the pharmacist. When you buy those medications, the staff will usually question you as to if you're on any other medications. So they're checking that it's not contraindicated with the other medications you've got. They also check whether you know how to take it, and they dig a little bit deeper. Prescription-only medicines, as the title states, these are ones that you can only get providing you've got a prescription from that appropriate qualified practitioner. So that might be a doctor, a dentist, a nurse or midwife prescriber, anyone who's appropriately qualified to give you that prescription. Then general sales lists. These are ones that don't require prescriptions or pharmacy medications. You can buy them over the counter. So things like paracetamol, ibuprofen, things like that. You just cough medicines. You can buy them across the counter. You don't need to actually ask anybody about them. Excuse me. And then we've got patient group directives. So sometimes, particularly within midwifery, we have a large group of people that might require a particular drug. So the one that comes to mind is Oromorph. Okay, so Oromorph doesn't sit on our midwives exemptions, but often we use it particularly for latent phase of labour. But we don't know those individual women who are going to need it, so we can't write a prescription or get the doctors to write a particular prescription for a individual person, because we don't know who's going to need it and who's not. So it's a generic, not a prescription really, but a instruction for the supply or administration to a specific group of patients that we can't individually identify. The thing with patient group directives is you have one per drug, and you as the person that's going to be administering it have to have undertaken the training. So generally they last for about 2 years, the PGDs, and then you have to do your training again. So you would have training around the drug, the normal doses, routes of administration, contraindications, side effects, all of those things, so that you are fully aware of all of the pros and cons of that drug, so you can have that discussion with the person that you're planning on administering it to. And it is only you, as the person having undertaken the training, that can administer it and sign for it. And in that box where we said that you would normally put the midwife's exemption, in the prescription signatory bit, you would write PGD. Now, the thing to bear in mind here is students cannot administer a medication under a PGD unless they have undertaken that training. So you can't watch a student administering something that is a PGD. If you want the student to administer it under your direct supervision, you need to get a doctor to prescribe it. Then controlled drugs. So these are things in maternity. It'll be your diamorphine, your pethidine, and your morphine. There is very strict legal requirements about the use of controlled drugs and the storage of controlled drugs. And so I would suggest that you look at your local trust's policy, but generally these need to be kept within a locked cupboard, within a locked cupboard. There are very strict requirements. It needs to be 2 registrants that check it. And you need to go together to actually check that they're being administered to the correct person. So some of these, pethidine, diamorphine, are on midwives' exemptions, and so we can administer them in certain circumstances, and that's usually in labour. And only those circumstances. We can't, with the midwives' exemptions, you can only administer them under the circumstances that they are on the list for. So I couldn't potentially give somebody pethidine for post-operative pain, 2 or 3 days after they've had an operation, because that's not within my sphere of practice, if that makes sense. Students cannot give controlled drugs. They can be involved in the preparation of controlled drugs, but they cannot give controlled drugs under a midwife's exemption. So looking at some common routes of administration in midwifery, we've got our intravenous, so that would be things like your IV fluids, Hartmann, saline, blood sometimes. Intramuscular, most commonly that would be your oxytocin post-delivery. Anti-D is an intramuscular injection. Sometimes antiemetics are also given intramuscularly. Equally, antiemetics are sometimes given intravenously. Subcutaneous, so these are not going into the muscle, they're going into that cutaneous layer. That tends to be things more like your deltaparin, your clexane, those long-term blood thinners. Orally, obviously, most commonly in maternity is paracetamol, ibuprofen, antibiotics, blood pressure medications. Per vaginum, again, in maternity, very often it's your induction of labour medications, so your Propest, your Prostins, but could be things like Canesten for the treatment of thrush. And per rectum, most commonly in maternity situations, is diclofenac post-suturing or post-caesarean section. And inhalation would be your Entonox. So the midwife's exemptions, they actually are detailed in Schedule 17 of the Human Medicines regulations, and I will put a link to that in the description below. And it sets out which drugs we can give in which circumstances. It's also in the NMC's publication Practicing as a Midwife in the UK, and that the whole thing sort of sits fairly easy to read in Appendix 3, I believe it is. And again, I'll put a link to that in the description. So Practicing as a Midwife in the UK, and obviously the Medicines Act, say that we can supply all general sales list and pharmacy medicines in accordance with our scope of practice. But that's only those ones that are included on the midwife's exemptions. Okay, it's not just, I can buy cough medicine over the counter, so I'll just give her some of that. It is the ones that are included. Medicines that are not included in the midwife's exemptions, okay, so that includes the general sales list and pharmacy ones and specific prescription-only ones, will need a prescription, a patient-specific direction, so that's one that's for a specific patient, or a patient group directive. Okay, so we can supply and administer a limited list of POMs, again, in there, and you'll find the list of what those ones are within Schedule 17 and in the appendix. So it tends to be things like anti-D, most of your emergency drugs, so your carboprost, oxytocins, Hartmann's, you can put those up in an emergency, okay, not just generally. So looking at student midwives, so midwives can also supply and administer a limited list of prescription-only medicines. So these, but it is in accordance with our sphere of practice. So they're things like anti-D, vitamin K. In emergency situations, things like carboprost, the oxytocins, IV Hartmann's. The full list is in that appendix of Practicing as a Midwife in the UK and in the Schedule 17 of the Human Medicines regulations. So thinking about student midwives, okay, all medications administered by student midwives must be under direct supervision. You shouldn't really be giving even paracetamol to a student and say, oh, can you go off and give that to Mrs. So-and-so? You should be, as a registrant, the midwife is responsible and accountable for ensuring that that medication is given to the correct person at the correct time and the correct route. and all the other checking requirements that we should do with drug administration, medicine administration. And then you're signing to say that you have witnessed that person actually take that medication. So if you are not there, then how are you actually legally signing to say they've taken it? Student midwives can't administer controlled drugs unless they have been prescribed. So under the midwives' exemptions, they can't administer pethidine or diamorphine, but should a doctor prescribe that medication for parenteral use, then the student midwife can administer it under direct supervision. Okay, you need to be very clear of that. So not under the midwives' exemptions, but if it's prescribed, then that's a different kettle of fish. But they can be involved with the checking and the preparation of that medication, just not the administration of it. You should never hold the keys as a student midwife, and this is particularly difficult for short course students who are already nurses or international midwives who are waiting for their NMC PIN to come through, because they've been in positions where they're used to managing their own caseload and administering medications, but you're now in a different role and you are working as a student midwife. You're not working on your nursing or midwifery PIN or your previous qualification PIN. You are working as a student midwife, therefore you should never be holding the drug keys. So finally, you should be aware of the common drugs that we administer in maternity and the contraindications for those, common reasons why we would use those drugs, contraindications for using those medications, the most usual doses. Whilst we don't advise on doses, that's out of our scope of practice, you should have an awareness of what the most common doses are for the more common medications that we use. The side effects of those drugs, because remember, if we are giving women all the information they need to make an informed choice, you should be able to say to them, well, this is why we're giving you this medication or suggesting you take this medication, and these are the possible side effects you might have. So if you're ever in doubt, don't give it, get some advice. My personal go-to is the pharmacist, because the pharmacy know much more about medications and contraindications than I will ever know, and I suspect more than doctors know as well. So they would be my first port of call. But if if you've got a doctor on the shop floor, you could double check with them. But I personally, as I say, I would go to a pharmacist. And there you have it. I hope you found that useful. I'll put the links to the relevant legislation and NMC documentation below in the description. I look forward to seeing you next time.